Again, appreciate everyone's indulgence there. Nice to take a break after. We actually had about, I had 63 public comments on my tally. So we appreciate all the comments, as well as continue to appreciate people's respectfulness of the process as we move forward. I will bring it back to the board and ask the board if there are any questions of staff prior to entering into deliberations. Supervisor Gorin.
Well, I have a number of questions, and thank you all for being here and your patience for sitting through. I'm not sure it's a record, but it's pretty close to a record, and the passion exhibited by everybody here and the great intellect of diving down into this issue is pretty impressive. So I am at a disadvantage because this is my first maiden voyage into the fluoride issue, and my learned colleagues here have had to go around about a year ago, and so they might have a better judge, a better source of information than I do. But I have a couple of technical questions. Let me get my pad of paper here. First of all, I really want to understand the scope of the challenge that we are confronting. I think there is no one in this room that disagrees with the seriousness of what we're facing. And I have visited the dental clinics at what used to be the Southwest Community Healthcare Clinic, and seen firsthand and talked firsthand with families suffering, with their children suffering from serious dental disease. And in fact, I was telling Susan Cooper, I've seen a number of my former healthcare professionals. That gives me sort of the heebie-jeebies that I'm not brushing my teeth or flossing appropriately in discussing this. But I want to understand the target population. We have a lot of facts and statistics about this serious healthcare issue that we find ourselves in. And yet we know from the situations here and the stories here that we have people who have raised children on unfluoridated water with pristine health care. And we know we could probably have another child for whatever other reasons with serious oral illness and dental decay. So how can we, I want to know the magnitude of the problem, where the population's located. We can speculate where some of them are. Southwest Santa Rosa, for example. Probably a strong correlation with poverty, especially now with people losing jobs and lack of access to dental care. How many thousands of children are we, and is it only children? Obviously adults have some problems too, but what are we looking at?
Well, I'll start and then perhaps pass to Dr. Pollack, but oral health issues affect most of the population. They affect rich and poor, young and old, my age too. I guess I'm getting towards the old side. They are more frequent amongst the poor. They are more frequent in minority children. In Sonoma County, our Sonoma County Smile Survey that Dr. Cooper described showed that the rates were approximately double among children attending schools with higher and low-income populations or among Latino children. So for those two groups, roughly 2/3 of the children who were evaluated in kindergarten and 3rd grade exhibited tooth decay. And for these higher, for the Latino children, for example, about 1 in 5 needed urgent or early dental care. But even for children, for white kids, and even for kids who were attending schools with a wealthier population, about 1/3 of the kids had tooth decay. And tooth decay affects adults, and it especially reaches and affects the elderly. So that when we talk about acting on these issues, fluoridation, for example, benefits people in all of these groups because its beauty is that it reaches the entire population. Those who are more affected by the problem will benefit more.
Well, let me ask you a question, because we're really talking about children predominantly as their teeth are forming, young children and teenagers. Do we have any demographic data? I don't know whether Rita is here. How many children do we have in Sonoma County under the age of 18?
We have over 100,000 children in school, correct?
Okay, 100,000 children. And so according to your statistics, let's just extrapolate. Out of 100,000 children, we have 42%, 30% with serious oral health problems.
With oral health, with some oral health problems, about half of them will have, actually it's about half of them will have some degree of decay. That was measuring just our elementary school children. We actually do not have data for our middle school and high school children in the county.
Okay.
We have national data for adults, but not local.
And let's speculate a little bit more. Of for example, 50,000 children, how many children, excuse me, consume water through our water supply? Either from the Sonoma County Water Agency through the retailers.
So of our 480,000 or so residents, approximately 350,000 receive Sonoma County Water Agency water. And about 250,000 are in the areas that would be extremely well fluoridated with fluoridation of the Sonoma County Water Agency, although the exact details of that would be clarified by the engineering assessment.
And my colleague reminds me that of course it's not just Roseland and it's not just Santa Rosa, it is the Sonoma Valley area, it's the Springs area, and it is probably any number of children in the other areas, Healdsburg included. Okay, so my second point is we could be here for the next month debating science about the effectiveness of added fluoride versus not. And we do see some charts which are interesting, talking about the fluoridated countries in Europe, for example. Some are fluoridated and some are not fluoridated, and yet all of the countries seem to show a similar decline in dental problems. Have you seen that chart?
I have. I'll pass that one to Dr. Pollack, and then I may add a comment at the end.
Those countries in Europe that have shown a decline, a lot of them also have salt fluoridation. There was a study done in Denmark recently published that showed that there was a declining rate of tooth decay by the increase in natural fluoride in the water. Fluoride toothpaste is a major factor in the reduction of tooth decay, and that is used by a lot of people. But as I mentioned in my study here in California, even though the overwhelming majority, 90% of kids were using fluoride toothpaste, we still found this 38% benefit of fluoridated water.
Supervisor Gordon, I'm sorry, I just need to intervene here because I do need to add something that I think is really important as we look at that. The Scandinavian countries have the best national health care in the world. They provide national dental health care.
Oh,
they have
absolutely.
for years, which is absolutely instrumental in their overall oral health.
And I appreciate that reminder, and you're absolutely correct. They have a incredible healthcare system. But the graph that I looked at, not only in Scandinavia, but it's other European countries as well, that show a similar decline. Now, obviously, part of that is the naturally occurring fluoride. And I think we do have that in some of our communities as well, for the Sonoma area, for example, naturally occurring fluoride. So it comes to the second part of my question, and you really sort of hit on it. I'm not a scientist. I'm not a researcher. I'm not going to dive down into 100 different scientific articles and try to really understand the essence. But I do understand enough to look at studies and want to know if there are studies that really separate the demographic information, as you talked about, with a community such as Healdsburg or San Francisco. I don't know how dated your study was, to really look at the economic cohorts of a study of a city that has fluoridated water and a city that has unfluoridated water.
So in the California children's, the oral health needs assessment of children, We looked at the fluoridated communities and the non-fluoridated communities, and we separated out the data accordingly. We looked at income level and poverty status within populations so that we were able to aggregate the data for California as a whole as to poor kids in fluoridated areas and non-fluoridated areas.
And thank you. I appreciate that, because that was the information that I've been looking for over the past couple of weeks and have not been able to find that kind of information that would really disaggregate the data so that I could compare cohort to cohort and provide some generalizations in that way. And I appreciate that. If I could at some point have access to that kind of information, I would be a better informed supervisor. I appreciate it. Now I really want to get down into some of the technical challenges that we find ourselves with Sonoma County. And I think I saw in the literature that we're proposing to add 0.7 to our public water supply. Is that the dosage that we're looking at now?
The California state regulation mirroring the federal regulation called for a range of 0.7 to 1.1, and it's the federal government is currently revising its standard to lower that to 0.7 milligrams per liter. It's not official yet, but it's expected that will be the target level to be used, correct? 0.7. I also just wanted to add one thing. Before I came here, and I was a professor at the Karolinska Institute in Stockholm, and it was dramatic, the differences that it made in healthcare, the universal access to health and dental care, the lack of social disparities, the lack of intensive advertising of sugary drinks and pushing junk food. There were many, many social differences that accounted for some of those factors.
And those are also very good to talk about, as we've had some histories of folks. I appreciate that. Now, the challenge that we have is we've talked about there are areas in the county that have naturally occurring fluoride. Sonoma area, for example, 0.3. And so, this may be part of the engineering analysis that is being proposed for the further recommendation. But I'm curious, because we have a water wholesaler providing water to water contractors, retailers, some of which rely a lot on well water, some of which rely a little bit on well water. Some of them have varying doses of naturally occurring fluoride. How do we, just off the top of your head, how do we engineer a system so that people will receive the absolute minimum dose and whatever we think it will be? I err on the side of caution. If we're going to do it, let's do it in a very small increment. How do we get there, because we have so many variables out there?
Thank you. And Pam or Grant, please correct me if I get any of this wrong. But after these many discussions we've had with the water agency and others, my understanding of the situation is the following. You would add the optimal amount of fluoride to the water agency water. That is mixed with water from local contractors in varying degrees, so it can never be too high, unless you had a locale with very high fluoride, which we do not in Sonoma County or in this service area of the water
is not
agency.
Considered high, it's low?
That would only slightly dilute the level from the Sonoma County Water Agency, so it would never go above the optimal level. The areas of Sonoma, Petaluma, Santa Rosa, Forestville, which have I believe above 90% of their water coming from the water agency, there's a map in the report, would be very close to the optimal level. A couple of towns would be slightly more diluted than that. Windsor would have a very low contribution of fluoride because most of their water is local. But it would never be above the safe and recommended level.
Are we anticipating that contractors will have to add fluoride to their water as well?
The situation with the contractors is the following. Again, in those cities that I just cited, they will be very close to the optimally recommended fluoride level because so much of their water comes from the Sonoma County Water Agency. They have the option of taking the decision to fluoridate their local wells so that they are perfectly at that level with whatever water goes out of their systems. but they are not obligated to do so. The California Department of Public Health is accepting the strategy of fluoridating wholesalers first. And if local retailers are able to fluoridate their local wells in the next 10, 20 years, they're obviously supportive of getting it perfect. But I think their basic approach is that the perfect should not be the enemy of the good.
And I appreciate that. A question regarding dosage. I've read a lot of things where no physician recommends that infants 0 to 6 months should ingest fluoride. Is that true?
No, there is fluoride present, for example, in formulas to some extent. It varies somewhat between the products, and I'll ask Dr. Pollock to help, but there is a recommendation that if a baby is primarily on formula, that they reconstitute with water that's easily available, that has the fluoride removed because of the variation in the fluoride content. That is something that's annoying, but on the other hand, you have to realize that fluoridating the water then relieves the vast majority of families, and most of our families in Sonoma County are breastfeeding, relieves the burden of providing fluoridated drops to your child. So,
well, and I think
there's
infants
a trade-off
don't receive fluoridated drops. It's just over the age of
fluoride
6
drops.
months.
I'm sorry.
And so are we going to provide, if we decide to go ahead with this, are we going to provide families with fluoride-free water to mix with formula?
No, it's easily available in pharmacies.
Okay, but they'll have to purchase it. Okay.
As they do the decision to purchase the formula, yeah.
Exactly. And my final question, I think, really has to do with be directed to our County Council, Bruce Goldstein. We have an interesting water distribution center system. We have a water wholesaler, the water agency, governed with our contractors by a restructured agreement. And that restructured agreement, will we be able to decide to fluoridate our water and expect our ratepayers to pay for the fluoride, either the $8.5 million or whatever it turns out to be, plus the ongoing operations and maintenance? Mr. DeGabriel is still here, thank you, and he suggests no.
You've got a check. Through the chair, my understanding is that if there was to be fluoridation through the water agency system, that, as you mentioned, there's a restructured agreement that the water contractors would have to agree to the change, because adding to the transmission system or undertaking those types of activities are something that's contemplated that under the restructured agreement that there have to be agreement by the individual contractors. If the contractors agreed to do that, that it's my understanding that if they chose, that is a cost that could be passed on to the ratepayers if there was not some other outside funding to do that. Certainly Mr. Davis and Ms. O'Donnell, who are experts in this, but I think that's basically the situation.
And it's my understanding that the contractors would have to agree unanimously to renegotiate the restructured agreement for this to happen.
To amend the agreement, it would need the unanimous vote of the water contractor.
Okay. If the contractors decide not to renegotiate and decide that they really do not want to move forward with this, it's not a priority on their part, and they've sort of indicated that that is true. And I guess my question should be directed to our professionals. Do we have other sources of funding for the capital cost and the O&M costs each year?
The first question is how much is it, which is the purpose of the board action that's requested today to obtain an engineering assessment so that we actually have an accurate cost estimate. In other cities, most of the capital costs have been funded by external funders. First Five has been an important contributor. In the past, the California Endowment was. I think the challenge for the county, once we know what the number is to put together a financial plan that would be acceptable.
All right. Are we anticipating that we might look to the First Five funding, which is not going to go very far in covering the $8.5 million cost.
Again, I think the first challenge is to know how much it is, and then to try and put together a combination of contributions, whether from First Five or private
I
donors
believe we have
or other sources.
$52 million
to attempt
of
to-
reserves also in the Sonoma County Water Agency. We have $52 million of reserves. We just reviewed that a few weeks ago.
Okay.
That would be something we would work with the CAO's office and yourselves to try and understand how best to address.
Okay, great. Thank you all for your patience and your answers to your questions.
Thank you. Are there other questions of the staff? Supervisor McGuire.
Thank you very much. Just a few, and just in regards to the, if you will, the return on investment. In one of the items in the staff report, you said every $1 invested in fluoridation saves $38 in dental expenses. Can you go into the details of that?
Yeah, that was a study from Louisiana with Medicaid children, and it was based on costs of dental services provided to children in the fluoridated and non-fluoridated parishes in Louisiana, and they came up with that ratio.
Okay. I have a cost of about $400 million in regards to the 83,000 visits to state emergency rooms that are uncompensated for individuals that have dental disease and have an oral health emergency. Do we know what that's statewide, do we know what our cost is? And that's something I'd be interested in, because that's something we haven't talked about. We continue to talk about what those potential upfront costs are, but what are we spending year after year on emergency room visits? I would expect it's in the millions if it's $400 million across the state on 83,000 visits, and that was according to the Sonoma County Task Force or Health Report. But that's something else I'd like to be able to hear back. I think the board would, because I think that's another significant factor of what taxpayers are already spending on unreimbursed care when it comes to oral health emergencies as well. So that's something I'd be interested that you can come back on. The other, there's been a lot of concern, and this is not a leading question whatsoever, but the impacts of fluoride on individuals' health. Can you go into that? Because I know that is a significant concern of a lot of folks that are here today about potential impacts at the levels you're talking about on individuals' physical health long term.
I'll start. It's very important what you said, the levels that we're talking about, because fluoride at the levels we're talking about is beneficial and is not toxic. Certainly there are toxic levels of fluoride that people get exposed to through occupational exposure and other exposures. But at the levels we're talking about, the only effect might be a 10% increase in mild dental fluorosis as any additional effect over and above the reduction in tooth decay. And the mild dental fluorosis has been shown, those teeth with mild dental fluorosis have been shown to have less tooth decay.
Just adding to his comment, I think that's one of the very confusing things about what we hear. So for example, the study on IQ that's being cited very widely, that was reflecting studies done in China in areas of more than 10 times, many of the areas varied a little bit, but more than 10 times the levels used for water fluoridation, or areas that had burning of high fluoride coal in China. So many of these studies are reflecting very different situations that get you into that toxicity range. Oxygen is toxic if you get too much of it. Water is toxic if you get too much of it. Many natural things are toxic if you get too much of them, and fluoride is something similar. Necessary in small amounts, toxic when you get way too much.
That's great. I think Supervisor Cree, you had a follow-up?
Just to follow up to that question, assuming that people are drinking the healthy amounts recommended of 8 and 9 glasses of water per day, or whatever it is, the number today, the levels that have been studied under that nexus don't reach the hazard potential of, I mean, that's my understanding that scientific research says that even assuming someone were to drink twice as much water as recommended for dietary, that you wouldn't be reaching the level of toxicity. Is that incorrect? Is that correct? Is that, because I'm trying to understand the science behind this too. I mean,
Well, let's put it like this. The Environmental Protection Agency for the United States has set a maximum for naturally occurring fluoride in water of 4 parts per million or milligrams per liter. A secondary standard of 2 parts per million to avoid the objectionable type of dental fluorosis. And in fact, communities which have more than 2 parts per million of fluoride naturally occurring in water, that the residents of that community are given a warning that children under the age of 9 should not drink that water while their teeth are developing. So we don't have any of those communities in Sonoma County, and very few in California as a whole.
I'd add something, just clarification in your question. Your adequate intake as an adult male would be 4 milligrams per day. If you drank 8 cups of water, that would get you 1/3 of the way there. 8 cups of fluoridated water would get you 1/3 of the way there. So this makes a modest contribution to you reaching your adequate intake, but it doesn't even come close to going past it.
Right, and that was the point of my question.
Supervisor McGuire.
My last question, I want to talk about the issue of incidental runoff. I am not an expert. I come from a community that's been fluoridated since early 1950s. I know that there is significant concern from the regional board in regards to incidental runoff, particularly in parks, that may be irrigated with treated wastewater. I have not heard that water that has been infused with fluoride has been an environmental concern. And again, this is not a leading question. I am not an expert. I just want to hear, is that a long-term environmental concern about the incidental runoff from parks, et cetera, into the greater storm system that could eventually end up in the Russian River?
I looked into that when I put together an article on water fluoridation in the environment that was published 9 years ago. It's on the CDC fluoridation website. One particular study was done in Canada that showed that the effluent, the runoff of water and sampling of that water was considerably lower than the fluoridation level. It does not concentrate in the soil or water, because soil actually absorbs some of that fluoride, but it also it does not affect the fish in rivers downstream or anything like that. This is that.
Thank you. Any other questions of? I do. Thank you very much for the presentation. Thank everyone for their patience. My questions really had more to do with my concerns. Quite frankly, had more to do with the financial and logistical concerns, and basically how do we pay for it and how do we continue to pay for it. But I do have a few questions that I want to ask. And I want to fully understand the case of the uneven dosages, or taking into account the natural fluoride level. Does that necessarily mean that we'll use Sonoma Valley, say, is it 0.38 in Sonoma Valley? That would be the 0.7 would be the difference between that 0.7 and 0.38 would be the maximum additive amount, since it's naturally occurring there, or is that only in the well water that's not connected to the aqueduct in Sonoma Valley?
The 0.38 value, if I'm not mistaken, Pam, was from the local wells in Sonoma. So the values for local fluoride that are in the report reflect only the local wells. The concentration now in the water agency is 0.13. So raising the water agency to 0.7, the concentration that reaches consumers will be the average of the 0.7 with whatever percent of local water is added in its concentration of fluoride. So in Sonoma, that would mean it would be 0.6 something on average.
Okay. Maybe I asked that wrong, and maybe Sonoma Valley doesn't augment their Sonoma County Water Agency water with the well water. But I guess say Roanoke Park, which actually has a significant amount of groundwater, and whatever their naturally occurring fluoride level would be where we would add then the maximum dose to get to 0.7. Is that correct?
So Roanoke Park, and there's a table on page, sorry, just looking for the table. Roanoke Park has a very low natural fluoride concentration. It receives a slightly higher percentage of water locally. Roanoke Park 74% of its water comes from the water agency, 26%, this is an average of the last 4 years, it varies over time, 26% was locally produced. So on average, their water would be 74% of the optimal fluoride level, although it would vary depending on how much they use their local wells. Rohnert Park, if it wished to be perfectly fluoridated, is actually the most complicated city because it has so many local wells, although each one puts out a relatively small volume. So they would be about 3/4 of the way to optimally fluoridated, but not perfect. So there's still clinical benefit from that.
Okay. And, you know, tell me if there's different, I heard a few people mention different types of fluoride, and I heard you say, you know, fluoride was, someone said fluoride ion is a fluoride ion. Can you just briefly describe what it is that the actual mineral that we're adding to water, how it's manufactured, where it's collected, how it's derived, and how it actually gets put into the system? So
I'm going to start and then ask for an addition. It all comes from crushing up rock, basically. And there are 3 different formulations that are used. One is sodium fluoride, which I believe is a solid. One is a liquid form that is usually used in the larger systems. All of them have to comply with very strict national requirements for products that are used for potable water. That includes very rigorous limitations on any contaminants that can be present in them. For example, arsenic and lead and things that people are raising. Those are very rigorously controlled not to raise the levels in water. Would you like to follow up? Is there any evidence of difference between these 3 compounds and health effects or risks?
When these chemicals are dissolved in water at the concentrations we're talking about, you're left with a free fluoride ion, which is the same no matter what the origin of the chemical was, and it's the same fluoride ion, and it's not like Prozac or something.
Okay. No. And they tell me, so the 1:38, that ratio, and I know that you mentioned that it came from a study in Louisiana that talked about Medicaid children. So I assume that to really extrapolate the savings here would be to take the proportion of Medicaid children, and that would be 1:38. But you know, perhaps like my own children, that savings would be something less, correct? So we're looking at a number that could be different from that, but.
Well, okay, so Medicaid fees in California are very low, and that is dental fees to dentists, what they get compensated for. So it's useful to use those Medicaid data. Obviously, non-Medicaid fees and children are going to benefit who are not on Medicaid, where the parents are going to pay either through their own pocket or co-pays with insurance. The fees are going to be much higher than the Medicaid fees, so the benefit may in fact be much greater.
Okay. And then finally, again, getting back to the how do we pay for it and how do we continue to pay for it question, and understanding that the restructured agreement with the water contractors would have to be reopened. And I'm not sure if this is a question for Grant Davis of the Sonoma County Water Agency, but you know, it opens up a Pandora's box in some ways, because the last time we opened up the restructured agreement, it took, what, 8.5 years to bottle it back up and close it again. Because I know that fluoride is not the only issue going forward on that particular piece. And I guess the $8.5 million that's within the report, where did that come from, and how much more, and, you know, what level of dollar amount on the capital improvement cost is that based upon, and what would we get in addition for the additional report, engineering report, in terms of a dollar amount? How much tighter are we going to get that? What's the margin of error between the numbers we have now versus the numbers we'll get at the end of spending the $100,000 or so?
I would say that the engineering report should give a significantly better margin. We've requested a Class 3 engineering report, which has a defined variation of 15 to 20% on the cost estimate. The one in the report was done by an engineer working with the California Dental Assistance Foundation, based in Sacramento, who did a calculation simply based on averages and on their maximum number, so it wasn't done on site, looking at our facilities. I hope that the actual cost will be lower, and that was a conservative estimate. The cost in San Diego and some other cities of the operations and maintenance is considerably lower, I believe, and we'll have to see what this engineering assessment gives us in terms of the operations and maintenance cost.
Okay, I appreciate that. Thank you.
Although I'm still researching some of that data for you.
Okay, thank you. I appreciate that. I'm not sure who wants to start. Supervisor Zane, are you raring to go?
Sure, all good. Thanks. Thank you. You know, it's lots of pages of reading, good reading. Thank you for the public that came out today and shared their opinions and all of their letters. And, you know, I wanted to start by saying, you know, I've actually spent my whole life in healthcare in terms of, and read lots and lots of research over the years and done a few research papers myself, and even had the privilege of authoring several of the national healthcare resolutions along with Rita Scardacci in the last couple of years for our legislative platform for NACO, which stands for the National Association for Counties. And I think that one of the things that's really important here to note is that this county has taken a very, very aggressive approach to providing the best public health we can, and especially in terms of prevention, because we believe that prevention is absolutely critical. You know, we talk about cost here today. You know, what is the cost of human suffering? Can we put a dollar on that? Because the human suffering out there is huge. It's great. And yeah, I see your sign, and by the way, as a CEO, thank you. And I've looked at that research too, but as the CEO for the Council on Aging for 10 years, there was not a week that went by that we didn't struggle to find a dentist to provide health care for one of our seniors. Because Medicare and Medi-Cal doesn't pay for dental health care. And there's so many of those seniors had horrible tooth decay and incredible suffering, incredible pain. So it does affect more than just children. But you know, there was a lot of reference to those people. Well, those people happen to be 82% of the people who are in favor of putting fluoride in our water because of the longevity studies on the overall healthcare benefits. And those people are the people that I ran for office to represent. They're children, they're minority children, they're poor children. They live in all of our districts, and guess what? They're not here today because they're children. And they're also working too. They're not here today. But those people matter. You know what? They matter. They matter. And I want to say that very emphatically. And those are the people who are suffering right now. And if we have a policy that we can make from this dais that is going to have an effect on reducing human suffering and improving their overall health care, by God, it's not just a legal obligation. It becomes an ethical and moral obligation. And the people who came forward today who are providing those health care services, the dentists, the pediatric health care, Sutter, Kaiser, St. Joseph's, Roseland Pediatrics, Community Action Partnership, North Bay Leadership, Santa Rosa Community Health Care Centers, Pediatric Dental Initiative, Sonoma County Office of Education, California Parenting Institute, Sonoma State Nursing School, Santa Rosa JC, all those providers that came forward who deal with this on a day-to-day with real human suffering. Thank you for them, for them coming forward, because we have heard what it's like to not have sufficient preventative dental health care. And we know that we can make a choice tonight in terms of policy that's going to prevent human suffering and help us become the healthiest county in California and in the state and in the country. And by the way, we're behind the curve. Over 70% of the nation has fluoride in their water. We are so behind the curve here. And you know, shame on us for being so behind, for not having the political background. I would listen to you, and you will now listen to me. And I'm not going to keep going. Please stop.
public like that. That's thoroughly obnoxious. Agreed.
Please.
Yes. You're supposed to represent us.
Thank you, Brenda.
Not to be. I'm in your district.
I'm not going on till they stop. Okay. So, the American Medical Association, to just name a few of the national, the American Cancer Society, American Dental Association, Child Welfare League, the Robert Wood Johnson Association, the World Health Organization, the U.S. Department of Veterans Affairs, the Centers for Disease and Control and Prevention, the Alzheimer's Association. Those are just a few, folks. There's about 3 more pages here too. I mean, this is an ethical issue. It promotes social justice by reducing health disparities. We know it's highly beneficial to the population. We know it's going to reduce tooth decay by 30 to 50%, and it does no harm. Is it the right thing to do?
You have to really refrain from shouting out in the audience and show some, decorum, please, as we continue.
You guys, but don't be putting us down.
You're here to listen to the board's deliberations. This is part of the democracy, and we appreciate that. So if we can show some respect and actually behave like adults, we'd be good to go.
I wholeheartedly support the recommendations, and I want to thank our medical officer, who we happened to steal from New York City after she did a darn good job working for them in terms of preventative health care issues. It's one of the pillars. I don't deny that it would be a good idea to tax the sugar drinks. I don't deny that it would be a great idea to make sure that we provided perinatal education for everybody who's going to have a baby in terms of how to care for that baby's teeth. I don't deny that every single one of those pillars is important and critical, but this issue affects all of us. It affects all of us. It is a social justice issue. It is a health disparity issue. We have an opportunity to make some great policy today. And I want to thank our medical officer for all the work that she did.
Thank you. Supervisor Carrillo.
Thank you, Mr. Chair, and want to thank the public for taking the time out of their day to be with us this evening, this afternoon, recognizing that I too have received numerous and dozens of emails, letters, and phone calls from my constituents in the 5th District, as well as constituents and residents of the other districts. We recognize that this is an issue that concerns many. I think we heard from both public health professionals, we heard from community residents, and folks that are generally interested in the well-being and the health of the community. I think one of the things that we are trying to do in this county that really does stand out is focusing on all aspects of life and all aspects of health to increase and enhance the quality of life of our residents and our constituencies. These include looking at the income disparities. I myself, like many of the folks that came here today, was raised in Santa Rosa, though prior to living in Santa Rosa, I lived in Mexico City. Of course, the water in Mexico City, you use it for things that usually don't come with ingestion. I was raised that, as a child from 1.5 years to 5.5, we just didn't consume the water in Mexico City unless you boiled it, and were able to do it that way. And it was a culture shift to come to the city for my parents to change that dynamic, and understanding that the water that was coming from the tap was actually some of the best water you can get in California, some of the best water you can get in the region. And yet, as I see some of the dynamics within the community, I think we had a couple of speakers today talking about I won't use quote unquote, those people and the vendors and so forth. And those are all things I think we do need to address. The sugary drinks, the soda pop, the candies. I mean, what we consume and the diets that we have. Those are all aspects that I think we're working on. The focus today is to promote and advance the oral health, the residents of this county. And I recognize that there's different perspectives on what that entails. You know, for those that came here today and want the board to focus on more outreach, to focus on more education, to focus on more advocacy, assisting the kids and the families to change their habits, this is exactly what the board is poised to do. We've been planning that since 2006 and 07 through the Health Action Initiative. We're poised to do that through the Public Health Officer's Office and Department of Health Services. We're trying to do that through the First Five Commission. Our partners in our community are doing so as well. You know, the county has not engaged in this initiative in a vacuum. We had a community meeting last week, and I know many members of the community attended. And in fact, you know, the next steps that we have in the item delineated here is to have a convening group, an advisory group that is going to walk us through this process of continued stakeholder involvement, and this is from the water contractors to the members of the community alike. You know, it has been, and I appreciate Supervisor Gordon, you know, your notion that, you know, this is really your first opportunity to engage with the public on this issue. But, you know, it's been 3 years since our board was presented with an update on oral health issues and really saw the epidemic that we have in this county. I have seen personally, not only at the clinic, at the Pediatric Dental Initiative, but I've seen some of these kids in our local schools. And I recognize that in order for us to, you know, focus on this issue, it's not just an issue for the children, it's not just an issue for the poor, the low income, it's an issue for seniors, women in pregnancy. I mean, there's a lot of different components that are incorporated in here. We can't ignore the data and the statistics in this county when it comes to the oral health epidemic. I mean, we just can't ignore that. And it's not just the teeth that you see or the pain the kids feel. I mean, these are lasting effects that may determine a kid's success in school. It may determine their high school outcomes. It may determine how involved and civically engaged they are in our communities. It may determine how much we pay on the criminal justice side because our kids weren't healthy in schools, were in pain in schools, and did not feel that they had successful. Some of our kids in our schools don't smile.
That's right.
They don't smile. And for me, it comes down to a very simple notion. You either believe in the science and you believe in this is a solution, or you don't. I mean, that's, we can ask as many questions as to demographics. We can ask as many questions as to what the cost is going to be. We can ask as many questions as to what the scientists and the data and the research has told us over the last 3 or 4 or 5 decades. And yet, to me, it comes down to either one, you believe it's a solution, it's part of the 5 pillars we've identified, or you don't. I mean, that is the question being presented to this board. And I am here to tell you that in my analysis of the data, of the studies, and the research, and what I've seen in the communities, I believe this works. I believe it can work. Now, there's logistics in it, there's continued involvement, continued stakeholder process. I think that's all going to be part of where we go from here, but the focus today is to promote and advance the oral health of our communities in this county. We're not alone in this. There's cities and counties throughout the state and throughout the nation that are moving in this direction. I think we've heard most recently San Diego being identified, the county of Santa Clara being identified, and yet it continues to remain possibly the most cost-effective way for us to do this. And yet we absolutely have to look at the foods. We absolutely have to look at taxing the sugar drinks. I mean, there's no question that that is an opportunity to do it that way. Access to care for dental care. I mean, I was raised in this city on not fluoridated water, but I was a privileged kid whose parents focused on flossing, brushing our teeth, and had access to dental care. And I can tell you that not every child in our community has that ability to either, one, be so fortunate to have parents that understand that, to be so fortunate to have access to the dental clinics. And those are all issues that I think as a community we still need to address. This is not, there is no silver bullet. to a solution of oral health. But I do believe this is a main significant component that can make significant impact. I know many of you in this room will disagree with me on that. I think that, I look forward to hearing from the rest of the board members here. But in my honest perspective, you either, one, believe that this can help, or you believe that it can't. And I think that it can. And I apologize for those in this audience that disagree with me on this. But there is going to be continued involvement. There's going to be continued engagement with the public, with the stakeholders. And I'm going to just reach over here to our chair of the Technical Advisory Committee. We do look forward to the engagement of the members of the WAC and the TAC. I understand that the restructured agreement presents interesting dynamics and obstacles, and the financing. We're all hamstrung with resources and financial resources. I think that's going to be the biggest obstacle in my perspective. I don't think it's the science. I don't think it's the will. I think it's finding the financial resources to do it. But I've gone on far on too long, Mr. Chair, but I do appreciate the members of the public that took the time to be here. I appreciated their emails and their phone calls. I think I did come here with an open mind to listen, but given what I've seen, I do believe that it's a simple choice. You believe in it or you don't, and I do today. So thank you.
Thank you. Supervisor McGuire?
Thank you very much, Chairman. Thank you, Supervisor Zane and Supervisor Carrillo, and thank you to all of you for being here today. Many of you have, as Supervisor Carrillo had mentioned, have either written us and or given us a phone call, and we greatly appreciate that feedback. And then also sending us those studies. I know that each of us have taken the opportunity to be able to read those emails that you have sent in and the information, and your feedback and opinions are greatly appreciated. And know that all of you also have another place to be tonight and this afternoon, and we're really grateful that you spend it here with us. And I also want to say thank you to the staff from Health Services. You know that this has been a complicated issue in bringing this forward, and I appreciate all the work that's gone into that. And also know that this is a very personal and passionate issue, no matter what side you're on. And what I appreciate is that we're able to sit in these chambers today and have the discussion. And again, very grateful for that. Just a few thoughts, and then some areas where I'd like to be able to just provide a little bit of feedback. I know there's been a lot of talk about the potential negatives when it comes to the fluoridating our water. But there has been very little discussion, in my belief, on what the costs are that we're currently looking at when it comes to the tens of millions of dollars taxpayers are responsible for when it comes to our current situation of reactive and unreimbursed care. That could be within our oral health crisis that we currently are seeing now, to the issue of healthcare in general. And I think that if we take a look at what is going to be best for the patient, then also best for the taxpayer, it's taking a proactive approach, particularly when it comes focusing on oral health. And was reading through the Sonoma County Task Force on oral health. And my wife's a teacher. She teaches in high school, and know that there are issues on the high school level. But I could not imagine being a third grader, in fact 52% in Sonoma County, who have had a history of tooth decay. That's above the state average. And I think as Supervisor Carrillo had mentioned, third grader is not going to be sitting there still learning when they have significant pain in their mouth. We know that there were 83,000 visits to state emergency rooms for preventable dental conditions. On each visit, the average cost is about $5,000. That totals over $400 million in unreimbursed dental care via an emergency room. And again, that's why I want to be able to hear what we're having to spend on reactive care, which would like to be able to hear that coming back. There's also been a lot of discussion about low-income kids and adults. And not sure everyone will believe what I'm about to say, but I believe it. I think low-income population suffer disproportionately compared to everyone else. And if you look at our changing demographics in this county, we're becoming older, and that older generation is white, And we are growing also when it comes to Latino families in Sonoma County. And in fact, Latinos are the fastest growing demographic group here in Sonoma County. And when you take a look and drill down in the facts, Latino kids experience more untreated tooth decay, and they have more urgent need for dental care than any other group in the county of Sonoma. And again, we need to get in front of this. And the other issue is Denti-Cal. It's a joke. Medical reimbursement for Denti-Cal patients here in California is the lowest in the nation. And you're not going to get a for-profit dentist to take a slew of Denti-Cal patients. It's just not going to happen. It will not pencil out. And so what we are left with are patients going into the various medical centers, whether it's Alexander Valley in the north, the southwest here, in Santa Rosa to Petaluma, and having, as we had heard, 3, 4, sometimes 5-month waits. And that's just not acceptable. And then coming from the city of Healdsburg, and I know I have a bias, since the early 1950s, the city of Healdsburg has been fluoridating its water. And I also know that there are concerns about health risks, environmental impacts, and harm to pets. I can say, at least in the city of Healdsburg, those concerns have not played out. And I would be interested in hearing a little more when you come back on where the rest of the 70% of the nation's at in regards to those 3 variables of health risks, environmental impacts, and harm to pets. There's also been a lot of talk about roads and oral health today. And frankly, I think we've taken the same approach. This county has done a piss poor job at investing in infrastructure in the county of Sonoma. We have a $900 million backlog when it comes to our road and bridges. I think we are over that $900 million when it comes to untreated medical, whether it's dental or general health. And we have an opportunity to be able to start tackling that issue just as we are with roads and investing $50 million in roads this year alone. I think we have to take a cost-effective, proactive approach when it comes to oral health. And when we take a look at these 5 areas, whether it's access or education, dental solvents, fluoride varnishes, water fluoridation, there is not a one-size-fits-all that is going to be a magical pill. But I do think that water fluoridation is one of the areas that will improve our oral health crisis. And right now we are very aggressively working on all 5 variables, and we just can't keep up at the moment. So I say all that, not to preach, but just to share my concern in regards to where I see that we're at. And there's some additional info that I'd like to be able to hear, Lynn, you coming back with. Obviously, we need to really firm up those numbers in regards to the upfront infrastructure costs. I am concerned about using general fund dollars. So I would like to be able to hear what can be raised via alternative sources through a health services department. The water agency has some very significant initiatives on the plate right now. The biological opinion, the federal mandate is huge. So I need to get a better understanding. I think the board's probably going to want a better understanding too of how this fits into the current priorities with the Sonoma County Water Agency. I think that the other item is what we need to launch some significant outreach to water contractors, and I know this is going to be a sincere approach, but talking with the partners via the water agency, consumers of water and residents. But again, I think fluoridation, we do need to move forward on today. And I do agree with my 2 other colleagues that have already spoken that while this may not be a one-size-fits-all approach, this is an important step to make. And we'll be supporting the initiative as stated by staff.
Thank you. Supervisor Gorin?
Well, I appreciate all of the comments of my colleagues because you have had longer time to really think about this and in a holistic way. And I'm conflicted because I have not seen the science yet that would lead me to believe that fluoride is going to be, I think it will help, and I'm trusting your judgment, it will help. But without the other 4 pillars that we've talked about, we are not going to simply fluoridate our water and see miraculous cures and improved dental health among especially our disadvantaged population. Will it equalize? It will improve, but never equalize. And I did have a great conversation with some of our providers talking about we simply don't have the capacity or the funding to provide dental care for all of the children, let alone all the adults in our county. Our healthcare system, we spend an absolute fortune, and we know that we are not providing adequate mental health services, vision services, and certainly dental. This is a huge problem in the United States. We've talked about how important the healthcare system is in Scandinavia, and they are light years ahead of us in approaching the healthcare challenges. But this is what we have to deal with. And in talking with our providers, we don't see a solution coming forward under the Affordable Health Care Act, because the capacity is simply not there. We just talked about the fact that we don't have dentists willing to take Medi-Cal clients. And so if our healthy families and children are going to convert to Medi-Cal, we still have a problem. And so here's where I'm going with this. I am not going to say, no, we don't want to move forward. I do want to see the science. I do want to review that. I have some concerns about putting the $100,000 into engineering yet, but my colleagues, I think, are ready to go forward with that. I want to see, when this comes back, alternatives. I want to see something a lot more than just $90,000 to cap Sonoma to talk about health-based activities and updates of the SMILE surveys. I want to see what that education program is going to look like for $100,000 to the Lou Group. How is that? How are we going to get into the schools? How are we going to build capacity in the community to serve our children? I think Supervisor McGuire's questions about the unreimbursed medical care, but I've heard enough and read enough about the challenges with fluoride and perhaps the or the toxicity problems with fluoride. What are we, do we see, I want to see the science, I've seen some of it, maybe it's funny science, I don't know, about the effects of fluoride, the toxicity of fluoride. Does it cause hip fractures? Does it not? Is there a link between Alzheimer's? I don't know. Some of the studies suggest there are. Again, maybe that's one-sided, but maybe it's not a controlled science. I want to understand, if we do this, then what are the effects and the unintended consequences of this? I also am concerned about, we've come a long way towards permitting of incidental runoff and modifying our basin plan amendments to deal with this. If we're going to have a problem with our recycled water and how it's going to be used for agriculture, how it's going to be affecting our streams and creeks, I think we need to have a conversation with our Regional Water Quality Control Board about this before we go much further in that. My guess is probably not, or it's an emerging topic. I don't know. I'm very concerned about the kind of fluoride we might be adding. I'm very concerned about the dosage we might be adding with the naturally occurring, and the fact that people with infants, do we need to have an education program about infants? I just have a lot of unanswered questions by what we're suggesting. We're directing staff to convene a fluoridation advisory committee. Is that simply a committee that of agreeers, or are we going to have some, for example, environmental folks on there that are going to raise some questions about how we move forward? I want to have a mixed sort of stakeholder group on that issue to make sure that everybody's point of view is being developed. And so and again, I need to know how the varying fluoride levels are going to play out in all of our contractors. We know that Roanoke Park relies significantly on wells. I don't know, they have apparently a low level of naturally occurring fluoride. So Roanoke Park is going to be having a lower fluoride level than, say, Sonoma. How does that, I don't know. So I need to understand from the engineering and from the healthcare professionals how those varying doses are going to play out. And we better prepare ourselves because there are going to be a lot of folks out there who are still going to buy bottled water and they're not going to take it from the tap, in spite of all of our campaign efforts about how safe fluoride is, because it's just one more thing that they're going to be concerned about. So I have some details and perhaps more than you wanted to hear about. I think the community, at least a good portion of the community, wants to see not only this action, but some alternatives. And I have some real underlying concerns about the cost of all of this and how we would finance this. I'm not sure that we want to take our water agency reserves and just expend that for the capital costs and the maintenance cost each year, nor do I want to see our first 5 commission funding gutted to pay for this either, because they are financing really important programs. So I'm asking some Herculean asks of you.
Supervisor Creel.
Mr. Chair, actually just going to go a little bit further with my comments here. I just want to make sure that staff is comfortable with the direction being presented by the board. If I understood position from Supervisors McGuire and Zane, we're pretty much in tangent on board with the recommendation being presented here. We know that there's obviously some challenges. I actually would pose a question that the state law does mandate the 2 largest cities in this county to fluoridate their system if they can find the money to do it. So I actually would beg the question that we need to see some leadership from those cities if they believe this is in fact is an issue within their cities, because we're talking about residents that not only are county residents, we're talking about residents that are city residents and live within these municipalities. So quite frankly, I mean, I just want to make sure that we're considering this from a big picture perspective, and that if in fact we have an issue, an epidemic, a health dilemma in this county, it needs to be shared by the leaders and the representatives of this county, within the cities, within the contractors. And when we're talking about cost, I mean, if this board thinks it's the right thing to do moving forward, if it believes it's the right thing to do moving forward, financial resources, partnerships, thinking outside the box, that can all be thought out and constructed and really fully vetted as we move forward, recognizing that when you look at $8 million as a potential cost or $10 million potential cost, and then you compare that with the cost that you're seeing on the effects of high school dropouts, on the effects of kids not getting the health care that's necessary, of kids not being healthy, of families not being healthy. I mean, those are costs that we need to consider long term, and we need to look at holistically. So I just want to make sure that staff understands what the direction is from this board and is not confused or added to. I mean, I just want I want to respect the comments and the questions being asked here, but I just want to make sure that I understand where my colleagues are on this issue. And I also want to ask the question that is contingent upon us to encourage folks that are stakeholders in this to not only see this as a financial obstacle to how we run these systems. And I'm talking about the contractors here. If the cities within the county believe that this is an epidemic, that it's an issue, then they should be at the table as well. And this should not be solely the responsibility of the directors of the water agency. I recognize there's a relationship there, but I'm just throwing that out there. If it's a health epidemic and a health issue, we have to have that conversation too. Because yes, our responsibility is to provide water and water supply to the constituents, but our responsibility as elected officials in here, contractors alike, is to the community's health as well. So I just want to make sure that that does, and I apologize for going out there, but some of the comments that were made, it just brings a little angst in me. That, again, you either believe that there's a health epidemic or you don't. If you do, there's a way to it, and if you don't believe it, then don't put the resources where they need to be. I mean, that's just as simple as that for me.
Thank you, Supervisor McGuire.
No, thank you very much. And I think that's one of the reasons why I brought forward the issue of what we're looking at unreimbursed dental visits right now. Because I think what we're going to find, and if we're just using the one figure from the Sonoma County Task Force on Oral Health, $400 million cost. It's actually over 400, so I made it a little more conservative. $400 million cost on emergency room visits across the state. That's 83,000 visits a year. And comparing that with the potential of an $8 million investment, I think that's the piece of where we need to get at to be able to provide that information, because we're paying for it many times over now. So of what that potential original investment would be when it comes to infrastructure.
Appreciate that. Thank you very much. And we were taking notes as people were speaking. I think there's not much that's been said that can't be incorporated into the actions that's in front of the board. I do have two other questions, things that were brought up, and I appreciate everyone's patience. There's been a lot of discussion, obviously a lot of correspondence going back and forth, and there was mention of, I think this board does a great job in terms of doing its research, I can assure you. I know that I've brought home the Weston Price book a number of nights and looked through it, and appreciate very much the science that's been presented. Can you talk briefly about the cost and efficiency of expanding certainly the existing dental care, assuming the same money as opposed to the fluoridation issue? What could occur with, say, 10 million pumped into the system now in terms of the effect that we can make on the crisis that we have versus the 10 million on the fluoridation? And I understand it's kind of a little bit of apples to oranges, but it's been brought up a number of times through correspondence, and I think we even heard it a few times today. And I'm talking mainly about how many, my 3 kids did take their fluoride tablets. How many prescriptions of fluoride tablets can we get for 10 million in the county? How long would it last, as opposed to going down a path of fluoridating water? And then what would be the efficiency of that in the medical outcome?
You might want to add something. I did not cost that out in detail. I think the obvious issue, which is it's a one-time capital investment, so it's not, and I don't think it'll be $10 million, but it's not every year. So you can build a clinic, but that clinic has to be staffed. It has to have materials, it has an ongoing budget. Whereas fluoridation, you cover the largest expense upfront with a one-time capital investment, and the ongoing costs are relatively modest. So, if we had $10 million to spend every year, we could have a great dental program in Sonoma County that would make a difference. We won't have that to spend every year. We could definitely, I think, ramp up the sealants program. We could increase some of the issues. I don't think we would necessarily be able to get the number of dentists we need to see the patients who need to be seen. There are issues of availability and other issues. I think prevention is still always the best thing. Fluoridation is beautiful, not because it's cheap. It's beautiful because it reaches everyone, because it reaches them every day. It reaches every tooth. So that's its main beauty. The fact that it's not terribly expensive when you average it out is an additional factor, but its main beauty is the nature of prevention, so that you don't have to go find the dentist. But we could do a lot with that money, but I don't know that we could sustain it over time at the levels that would be.
I appreciate that. And I know that when talking about these, as you showed us, the 5 pillars for improving dental health, it's all 5 together. It's not one over the other. And although we're concentrating here on fluoride, as rightfully so, people are showing concern about that. It's certainly the access issue, which I think we've made great strides in this county in the last so many years. And as Naomi, I'm not sure if Naomi Fuchs is still here, but you hear about another facility being open, and that's wonderful, and more is better. I think on our education side, it's the same thing, making that, just continuing to reach out and to really find ways to directly engage those folks of all, socioeconomic levels of the importance of oral health care, especially for kids. A little bias there. And the dental sealants itself, and certainly the fluoride varnishes. And again, you know, everyone has anecdotal stories about, you know, my kids never had cavities, but of course we got great dental care for them. I had fluoride growing up, I had cavities. But of course, as I mentioned to the county council, you know, in Ireland when my parents were growing up, very few kids had cavities. Because if you did, they pulled your tooth out. And so my mom and dad didn't really teach me how to brush my teeth because their teeth were in a jar on the side of the bed. And you know, that's just the way it was in the 1930s in Ireland when they had no money and a brand new country. So that being said, hopefully in this country we can really give kids the advantage they need to actually succeed. And I totally agree with Supervisor Carrillo and Supervisor McGuire and Supervisors, everyone who spoke about, you know, God help a kid in class in pain. I mean, you know, kids should enjoy school, should be there, should be engaged, should be, you know, I think we all agree that that's a problem. And really, is it an epidemic? If one child, the idea that you'd have to bring a child into an operating room, put them under a general anesthetic to operate on their mouth of a preventative dental disease at such a young age, to me is really kind of heart-wrenching. And as a society, that should not be something that we put up with. That we really need to attack that and say, you know what, we got to do better. And we have to do better across the board. And if you look at the numbers, it's amazing to me also that, well, yeah, okay, on the lower end, twice as many kids have twice as many problems, or twice as many problems exist. There's still a huge amount on the other end. But this issue, I don't think it's necessarily just one socioeconomic class. It's across the board. And it partly because, obviously, our country has not dealt very well with health insurance. And within health insurance, then you've got dental insurance, which is kind of the, you know, the stepchild of the whole health insurance industry. So if you don't have the money, you're not out there investing in your health, and you close your mouth and you hope it goes away, and it rarely does, and you end up with a bigger problem down the road. So I don't think there's any problem, any issue in terms of trying to go ahead and do the right thing for all of our kids in this community moving forward. I do, you know, I want to make sure that I think at the end of the day, the dollars do count. Obviously, the dollars count. I am very worried in this case about the logistics and the financing and how we move forward. Like I mentioned before, the restructured agreement, the last time it was open, took 8.5 years to close. You know, getting unanimous support from anyone within the county is difficult at best. What happens if one entity, one jurisdiction says, no, we're good, we don't want to do that? They aren't required to do that. Does everyone else then pick up the dime for them? How do we actually do that with our contractors, with our ratepayers? Those are some really serious issues. I personally, rather than seeing the last item about going out with the preliminary engineering design report, and that's why I asked about what confidence we have in the numbers that we have in front of us, I'd really rather talk about the financial modeling going forward. What resources are we going to really come to bear to make this happen? And I have a feeling that you probably can find the $8 million for the capital improvements, assuming that's what it is, plus or minus the 15–20%. I do worry about the $1 million per annual cost going forward, or even if it's less, whatever that cost may be, however that gets instituted amongst the ratepayers going forward. Those are really concerns that I have. They're really more about the logistics and the financing, the financial model going forward. I also have some concerns with the first two items in regards to the measures of success. This morning we talked about the upstream investments. We had our partners here. We talked about the rigor that they had to go through to really kind of almost prove a return on investment. And I'm not sure I see that with these two items. I see kind of a PR campaign and we're going to go out and do some branding kind of thing and see who we can reach, but I'm not sure what we're going to receive in return for that. And I want to make sure that if we're spending that $90,000 and that $70,000 that we're actually getting some substantial return on that it's actually going to make a difference with this particular issue of, what is the outcome going to be that's going to be so much better off going forward. Also, as we come back, I'd love to see in terms of the Fluoridation Advisory Committee, again, what is the plan for that committee? How is that committee going to be not just formed, because I think we often throw together stakeholder meetings, and I think that you end up with, yeah, there's people that are very engaged within all these different special interest groups, but is that truly indicative of the entire county? How is that going to work? I do think that one of the biggest items that we need to tackle, and it's got to happen sooner than later, is to really engage our contractors. Because, you know, I realize, and I totally understand where Supervisor Carrillo's coming from. I think the cities don't see the same epidemic because the cities aren't writing the checks on the dental health care side or dealing with the dental health care side as we are here at the county. They're just dealing as a water purveyor to customers out there, and as a commodity, totally different, not looking at the health benefits and the costs that would be associated with it. So while I totally agree with that, the fluoridated water would end up saving county money, would it end up saving cities money? And can you actually make that argument with them across the board? You know, while we're all one big happy community, I think when you start talking about dollars within ratepayers, things start falling apart rather quickly. So I do think that there's some additional work to be done. I do think I also believe that the science itself, again, growing up in a city that had fluoride, and the fact that so many cities across this country do have fluoride, reading through the myriad of reports and trying to really judge, you know, as a layperson, what is the true science versus what is that stuff that's anecdotal or on the edge or in the toxic realm of the other issues that are kind of tweaking something over on the side. You know, in a perfect world, we wouldn't add anything to our water. We actually add what? Chlorine, and we add another material just because we have to get it through the pipes without the pipes rusting away. And we already do that. You know, it's funny that we care more about the pipes that the water passes through than the recipients at the other end. We don't care that the teeth rot away, but we care that the pipes rot away, and we're willing to spend additional money there. So I think we need to be consistent in our thoughts going forward. I do think that the amount of money that it takes is substantial. It's something that we really need to work on. I don't see this as something that's going to happen personally real quickly because there's a lot of moving pieces and a lot of stuff to go after and tackle. But I do think that it's important for us to move forward, acknowledge the fact that we have an issue, we have a health issue, and this is sitting in front of us. And to not move forward with this today, I think would be, from the health standpoint, irresponsible. And I appreciate everyone's passion. I appreciate people who think that, you know, don't add a thing to the water. But I think also there's no denying the science that's out there in terms of what return on that investment of that fluoride within the water, notwithstanding the fact that I look forward to the information coming back on the cumulative effects, environmental effects of the runoff, anything else that's out there, pull that together. I think that would be very beneficial for this board before we make the final step to actually insert fluoride in water. But what we are approving, or what I think I'm hearing, reading the tea leaves today, is there's 4 requested board actions. The first is to approve a contract with Community Action Partnership to lead community-based oral health activities and update the SMILE survey. And again, I ask that the measures of success and the kind of that rigor and the return of investment on that be really brought to light. The second item is to approve a contract with the Lou Group to conduct an oral health education campaign. And my personal comment on that is still the same, to make sure that we do understand what the return on investment that we expect to get out of that in relationship to the crisis that we are in. The third item is to direct staff to convene a fluoridation advisory committee. The fourth item, did I say fourth? Wait, 1, 2, 3. Fourth item, direct staff to continue with a process of community input from water retailers and other stakeholders, approving a contract for facilitation services for the process, for this process and for the advisory committee. I would ask within there, if it's possible at all, to expand that to include the financial modeling going forward, because I think that's where we really need to talk about it. I understand we need to come up with a fixed dollar amount. The truth is, on the engineering, again, the engineering study, it may be a snapshot in time that may end up being out of date by the time it actually happens. So, you know, I'm more interested about finding the sources of funds to make it a reality than trying to figure out today, you know, to price out the dream home that you don't have money in the bank to build. The last item, again, is approved contract to develop a preliminary engineering design report for fluoridation of Sonoma County Water Agency's drinking water supply. On that one, again, I personally could go either way, and I don't know. I think might be the only one there.
I agree with that.
Do you want to, if that's the case, maybe the best thing to do is kind of bifurcate this. If there's seems to be two of us on the last item that aren't so crazy about moving forward with the $102,970 preliminary engineering design report. I just want to make sure that we're all on the same page and staff is given the clear direction.
Perhaps with information from the financial modeling going forward, it might be easier to then move forward to the engineering process.
Maybe I can ask staff, is that time sensitive as compared to the other information, the other items on the action list?
I mean, an RFP has been done and a vendor selected together with the water agency. Some of our initial conversations suggest that it might be significantly different than the rough estimate we got from the CDAF report. I would prefer to engage in financial modeling with a clear target, because otherwise it's a difficult exercise to ask anyone to commit resources when we don't have an accurate and well-established target amount that needs to be mobilized. So it would be our preference to move forward with the engineering assessment
I
report.
appreciate that.
But
Supervisor McGuire?
Yeah, I was just going to mention, I think to be able to get to that, to sharpen the pencil and get to that bottom line of what that upfront cost is going to be is moving forward with the engineers. I think that's probably going to be some of the best money spent to be able to get that financial model back in regards to the upfront costs, which then we could go look at outside sources beyond the general fund once we have a firm number.
And again, my only point is if it's 6, if it's 8, if it's 10, and if we have 0.
But so just using this as an example, if I'm going to help fund, if our goal is to be revenue neutral when it comes to the general fund, and we are going out and potentially looking at additional sources, we're going to have to be able to give them that hard estimate of what it's going to cost us up front to potentially fluoridate. So I think that's the only item, I think that's going to be the most important piece on this, is moving forward the engineering study so that we can, at least I sleep better knowing exactly what it's going to cost us, and then we can back into that as far as looking at outside sources, and that's would be my approach.
If I can just add on it too, the source of the funding specifically for this, it's state and federal dollars that are the sources, if I understood correctly. And I'm seeing Director Scardacci nod in the back. So it's not like it's general fund dollars that are coming out of the general fund.
It says right here.
Stuff. You know, and I do believe that having some engineering done, you know, in coordination with the agency, I think that will also help engage more discussion within the contractors. And you know, I didn't mean to come off so strongly on my comments, because I do believe they play a critical role there. But having more information than less can help understand the fully costing out if this board decides to move forward or not. I mean, I think we're not making that decision today, but I do believe it's helpful to have some of those preliminary engineering designs to at least understand what financial model will need to look like if in fact you decide to move that direction.
And Chair, this would be my last comment on this one, is I would hope that if we can move forward on the engineering, be able to show the water contractors any potential grant sources. I would also hope that we could show them, as we talked about, what those costs are right now, as we had mentioned, of what it's costing us for unreimbursed care as well, so we're able to show both. I think that would be a good perspective to be able to have.
And I certainly would give you that if, like in the CCAs, where we're actually going and trying to improve the rates to the contractors. In this case, I'm not sure if we even know at this point if it's something that's going to be passed on at all. and whether or not the contractors need to approve of, the county or the water agency receiving grant funding for a capital improvement project one way or another. But I don't think that, I see 2 and I don't see 3, so I could read tea leaves moving forward. If there's not any other, I don't want to prolong the agony. If there's not anything else, I think we can go ahead and before us with, I believe that the comments that were added in terms of the funding sources, I think is really kind of one of the larger ones. Certainly, I appreciate the fact that the water agency's workload and priorities certainly need to be into the mix, as would any of the county departments. And I'm not sure if there's anything outside of that wouldn't be included anyway, outside of what Susan or what Supervisor Gorin had mentioned within her comments. Just want to make sure staff has full direction going forward.
Concretely, your question on the funding sources?
Would you like, through the chair, would you like me to summarize what I have on my notes?
Thank you.
So I had the notes from Supervisor McGuire that you wanted some report back on the health risks, the environmental effects, the runoff and impact on pets. A question about the upfront costs and how does it fit into the water agency's priorities. Supervisor Gorin had asked for a list of alternatives. I think Supervisor Rabbit, you asked that question and they responded here, but I think it would be helpful to come back with that data. And she also had talked about how the advisory group was going to be formed, who the membership was it going to be mixed, is there going to be environmental representation, so some question about how we create the advisory committee. And then there was a question about funding and how you built those funding sources and whether or not the advisory group could expand their focus in terms of the facilitation to look at funding sources, or you could expand the contract on the engineering report to also look at not only the cost but what available funding sources there might be. I also heard that your board was interested in measures of success built into the contracts, and in particular return on investment for the marketing pieces and for the outreach. And my last one was, how are we going to finance this? What are the sources of funds, which I think I repeated earlier. So those are the ones I captured.
Just one question. My impression would be that the engineering contract might not be the most appropriate place to try and clarify the funding sources, because that would be more of a political negotiation.
It could happen in the facilitation contract as well. It was just not very clear from the board direction.
I think in relation to the working with the water contracts, the facilitation contract could definitely engage in that, help with that discussion. It could be very helpful.
Yeah, that's where I see it.
Is that where you see it?
Absolutely. I was just going to say Director Scardacci is really good at that, so that'd be good. Yeah.
Everyone is good? We got everyone on the same page. I want to just make sure that we have.
I just have one more question, because I know that the staff's intent was to come back, I believe, in 2014 with some of this work and just some direction in terms of the timing for your board on some of these pieces. And maybe
About 6 months.
So I think
Is that-
most of the
is that gonna work?
timelines are already in the action.
Timelines are already embedded.
They're already embedded
Okay.
in the action.
So you're fine with keeping in the current timelines? Okay,
My general
excellent.
impression is we'd have the engineering report in June, and we'd then be developing the
That's fine. I
financial plan.
just wondered if you
after
wanted
that.
to change that. Okay, that's great, thank you.
Okay, we have direction. And I'm seeing any dissension from the board. Seeing none, that passes on a 5-0-0 vote. Thank you very much for all your work on this, for being here and for your patience. The board will now adjourn to continue closed session.